Yeah, so good afternoon, everyone. I'm Dr. Shefali from SigTuple Technologies, Bangalore. So I work as a consultant pathologist. Actually, our CEO and founder, Mr. Tatha, was supposed to come for the talk, but he was held up with something, so he couldn't make it. So I would just like to say, we would give you a brief introduction to what our device actually does and how it is going to be useful to the patient. So our end product, our end goal since the product was conceptualized has been the patient and how it's going to benefit the patient. So what is an automated digital cell morphology system? Okay, so it works exactly like how a pathologist works. So the technician makes the slide, he stains it, and then it is scanned in our device, just like how we scan it under a microscope. And then it identifies a monolayer, like how we do, where the cells are equally distributed, and it locates individual cells, takes images of it, and then matches it, image matching. That is what even our brain does. So when we do our MD, that is how we are trained. So image matching is what is done, and it captures high quality cell images. And by using image analysis technology and artificial intelligence, your machine learning, your neural networks and everything, it performs a pre-classification of the cells. And images are then presented to a medical technologist or a pathologist on a computer screen for final verification. Now, this digital morphology system, it is not new. So I just want to, give you a brief thing that it started way back in the 70s itself, where there were a lot of limitations due to which this did not click. So main was the cost, the data storage, data security. I think we've been hearing these terms since morning, right? And also there was a lack of familiarity or trust. This is one of the most important things, and this problem we face even today. And it is, I think, called as pathologist technophobia. So no, we don't want to, lose our microscopes and replace it with the laptop. We love our microscopes a lot. Just like our intensivists and our internal medicine people love their stethoscopes, is the same, yeah? So that is why it did not click, and also there was lack of faster processing systems and connectivity. Then in the 80s, what happened was there was a rise of these 3-part and 5-part hematology analyzers. So ye hai na, to kyun chahiye aapko morphology? Okay, so these are giving everything, your CBC, your HB, TC, your WBC counts, platelet counts in a jiffy, right? So they ruled the 90s, and thousands of cells could be counted by your cell sorters, your flow cytometry, everything started booming at that time. So now why it's taking, it's coming out in the open. So in the early 2000s, conditions to develop digital cell morphology systems were better. Then the concept of artificial neural networks, machine learning, deep learning came into existence. And they found more applications. So, building a product, but you need to apply it somewhere. You just can't build and, there's no use, there's no point, right? Then smaller footprint, faster computers and processors. This was a huge advantage, and better connectivity. So remote access is what was, achieved by this. So today I can sit in Vellore and actually see a slide which is being scanned in Bangalore and even report it. So that is the magic of this. So what were the challenges? Why this device was developed? So there's pressure to do more with less. As soon as we get a slide in the lab, the clinician starts calling, "Ma'am, what are you seeing? Are you seeing platelet clumps? I need to operate on the patient. If it is less than 1 lakh, I can't operate." So immediately we have to scurry, ask the technician, come on, stay in, and we have to detect the clumps. Sometimes we miss the clumps. So our device here, it locates the clumps, exactly. So your human error is, nullified here. Shortage of skilled personnel. So, there'll be few pathologists who can't identify blasts. So in your case of leukemias, it's so important to identify. So skill and, skilled personnel, we have a deficit. Then demands for shorter TATs, your turnaround times, clinicians want the reports immediately. Need for greater levels of consistency and standardization, need for new levels of connectivity and remote access, and need for greater levels of traceability and quality control. So these cases, like suppose the clinician is not happy with your report, you can always ask another pathologist who is more adept in the subject. Someone like from Tata can review the slide and tell you, yes, this is acute leukemia, and your primary pathologist is right. So that is the use of our AI 100. So CBC or peripheral smear is one of the most basic and primary tests that is ordered. And morphological analysis of peripheral blood smears and elements in these aid the clinician and also help him in deciding the next course of treatment. Traditionally, morphological analysis of the blood smear has been performed by our microscopy. This is considered gold standard still. So when we do our validations, the validation we do on our AI100 is always compared to our microscopy. So it's been like that and we want to change that, okay? By pre-classifying the cells using artificial intelligence algorithms, digital image analysis, it automates the blood smear review process and enables faster slide reviews. So your DC, your differential count is already done by the AI. And you can, and there's actually visual evidence, which is the most important. So nobody can question you. So your clinician cannot come and question you, ma'am, where are the blasts? I can't see it. So, see, they're right here. So you can all, there's proof. Visual evidence is very important. So what are the advantages? I'll just reiterate them. Eliminates need to perform manual differentials, which is laborious and time consuming. It has good reproducibility. It improves your turnaround time. Enables remote review. Digital archiving, easy retrieval of blood films. Like tomorrow, like after 2-3 days, we usually discard all the peripheral smear slides. So here, your smear is stored on the cloud, on your cloud storage, okay? Reduced fatigue eye strain, so good ergonomics. So we're always sitting near the microscope. We might have spondylosis, we don't know, right? Facilitation of morphology education. So the PG students can benefit a lot from this. So they will learn to identify the cells. They can keep seeing it, keep seeing the images. QA, training, and peer review in digital format. So in AI100, your pre-analyticals are very important. If the slide is not made properly or stayed properly, the machine will reject the slide. And we're also working on very badly stained slides also, so that it doesn't fail on that, but that is in the future. So at SigTuple, we're making healthcare better. We're democratizing microscopy by enabling AI-assisted remote review unhindered by geographical boundaries. And this is and we're not only limited to hematology, we are also venturing into urine microscopy. We are CE certified. We are awaiting US FDA approval. So it's one device, multiple tests, and we're also working on a universal scanner. So anything under the sun, your histopathology, your IHC, everything can be digitized. So we make it accurate, affordable, and accessible. So access your reports from anywhere, just like your manual. So we even have a feature where we actually show the field of vision, which is actually seen exactly like this under the microscope. So the pathologist won't have your phobia. So we also value our customers a lot. And we have received few awards. Now, I would like to hand over the mic to my colleague, Dr. Sharitha, who will take us through the few of the cases. So SigTuple has its devices in many remote locations, like we have one in Ashwini Hospital, which is an Adivasi hospital, and also in a lot of these Krishna labs. So we have a tie-up with Krishna Diagnostics where all our devices are placed. And these are few of the cases, interesting cases that Dr. Sharitha will take you through. Thank you.
Thank you, Dr. Shefali. That was a nice talk. Now, whatever Dr. Shefali has highlighted, I think, about the detection of cases, I'll just take you through a few cases, practical applications, like how it has helped so many patients around the country, basically. So these are the images taken by our device, AI100. That is like, you get RBCs. We differentiate into normocytes, microcytes, and macrocytes. So these are the different images that have been captured by AI100. So there are different poikilocytes as well. Macrocytes, teardrop, like, it becomes important in myelofibrosis. Echinocytes, it is present in most of the degenerated cells or in some hereditary conditions. Fragmented cells, again, it's an emergency condition, like where we have to report it immediately to the clinician. Target cells, like in thalassemias, you can get target cells, again, which helps the patient in early diagnosis and early treatment, helps the clinicians, basically. And this is one of the clinical scenario, what I was talking about, like, there was a patient who, it was in a remote place actually, where we have Ashwini Hospital it is in Gudlur. It is like a remote hospital where connectivity also is very less, but then we have placed our device there, and the pathologist there usually, if she is not trained in reporting peripheral smears as much as, we are trained in Bangalore or any other places like, tier 1 cities. So she usually scans the slides there, and our pathologist in Bangalore, we can have a look at the images and we can report it from Bangalore. So this was one of the case where a child came in the evening with hemoglobin of around 6 grams, and on the, every time, it's a young child with so much of, hemoglobin, so less of hemoglobin, we always have to suspect a lot of conditions. It could be leukemia, it could be any other condition. So if it is leukemia, then the treatment is immediate, and the treatment has to be started as early as possible. So if we have visual evidence like this, the pathologist can say that it is not leukemia, it is just anemia, and then you can go ahead with blood transfusions. So the report of this is microcytic hypochromic anemia. It is usually due to iron deficiency, and the diagnosis of iron deficiency anemia was given, and the patient was given immediate blood transfusion with iron supplements. So this is one more case where, especially in oncology centers, like, when the patient has undergone transplants, that if there is a transplant rejection, the first thing the clinician asks is are there, cystocytes on blood smear? So this was reported in the late evening when the pathologist, usually pathologists, they work 24/7. The clinicians can take off. I am taking that liberty to say, but because pathologists are, working 24/7, they don't have any, they don't take offs, even on Sundays at 12 o'clock in the night, because at least clinicians will have shifts. I think there will be one pathologist for the entire center, and that one pathologist will be working all round. So, at 12 o'clock, the technician calls and says, we have the sample. And then usually the pathologist runs back to the hospital to see the smear and see whether there are cystocytes present. So this is one of the case where cystocytes were seen, and the diagnosis was given. And this was...
You'll have to wind up.
Yeah, sure. Just to... Yeah. So this is one case of thalassemia which was reported. And malaria, again, which is a very critical information to be provided to the clinician, that also can be picked up by the device, and it was done through remote access. And neutrophilia in case of infections, eosinophilia in case of allergies, and leukemia also, the blast, as per our customers, I think most of them are happy. Few of them have problems with identifying the blast, but most of them are happy with blast morphology as well, and they can identify and also report leukemias with the help of AI100. And giant platelets, which is quite common in North Indian population and the Eastern population, they also, macrothrombocytopenia is a very prevalent condition in these conditions, and giant platelets can also be picked up by AI100. And also platelet clumps, which causes spurious thrombocytopenia. The analyzer may be giving the count of 10,000, and if you see on the smear, it will be like, flooded with platelets like these clumps. So it helps the clinician by not giving unnecessary platelet transfusions to the patient and avoiding unnecessary complications as well. So these are platelet, as my colleague was discussing, we are venturing into urine analysis as well, and these are the images that we have taken, that crystals can be picked up, even hyaline and granular casts, which are important in nephrological conditions, that also can be picked up, and RBCs and some of the E's can also be picked up. With this, I would like to end the talk that, most of the pathologists are, as my colleague was saying, phobia to this, because they think this is replacing, the AI is replacing the pathologist, but it's not like that. I think it's just helping us to work better with good collaboration, with good, expert consultations. Thank you.